2, 1. We are live now.
Respected faculty and dear friends, welcome to the Pediatric Trauma Symposium of Uttaranchal Orthopaedic Association. I feel myself privileged to be with such learned people this evening. I feel pleasure in introducing you all with our learned speakers. Our first speaker is Professor P.N. Gupta from Government Medical College, Chandigarh. He is a great pediatric orthosurgeon, a teacher par excellence. He is such a noble personality and ever ready to help anyone in need. I welcome you, sir. He will be speaking tonight about pediatric forearm injuries, current concepts in management. Welcome, Dr. Gupta, sir.
Thank you, sir. Thank you, sir.
Our second speaker is Professor Ravi Mittal from AIIMS, New Delhi. A humble personality, a great listener, and a noble soul, a helping teacher. He is a great innovator, and today he will be explaining his operation design for habitual dislocation of patella. Dr. Ravi Mittal, sir, welcome.
Thank you, sir.
Our third speaker is Dr. Jaideep Dhemele from Maharashtra. He is a pediatric orthopedic surgeon of repute and is doing complex surgeries with great ease. I am very thankful to him to accept our invitation on such a short notice. He will be discussing some very good, interesting cases from lower limb. Welcome, Dr. Jaideep.
Thank you, sir.
I would request all the panelists and Dr. Puneet to please show their video also so that the people get acquainted with them. Today we have four panelists, four pediatric orthopedic surgeons as panelists. Dr. Vivek Singh and Dr. Rama Pyari are from AIIMS Rishikesh, while Dr. Vivek Singh is associate professor at AIIMS. Dr. Rama Pyari is pursuing her MCH in pediatric orthopedics. Welcome, both of you.
Thank you, sir.
Thank you, sir. Good evening, sir.
Welcome. Now I would welcome, we have with us Dr. Saraswati Vishvanathan from Bangalore. She is consultant pediatric orthopedic surgeon for the last 10 years. Welcome, madam.
Thank you, sir.
We have with us another pediatric orthosurgeon from Uttaranchal, Dr. Chetan. Dr. Chetan, welcome.
Good morning, sir. Good evening, sir.
He is from Himalayan Institute of Medical Sciences, Jolly Grant, and he is associate professor and a researcher. Welcome, Dr. Chetan.
Thank you, sir.
So now we come on to the scientific material. I would request Dr. Gupta, sir, to please share his screen and start his presentation, sir.
So good evening, everybody. Are you able to see the screen? Are you able to hear me? Are you able to see the screen?
Yes,
Sir,
Great.
Yes,
we
sir.
are able to hear you.
We are able to hear.
So I'll be discussing about the current concepts in management of forearm fractures of children, a complete fracture or a comminuted one. And once it comes to management, there is a lot of confusion as to which ones to operate, which ones to keep conservatively, and once you plan to operate, what type of implant do you use? So the options are basically non-operative and operative, and again there is a confusion. And in case you don't operate and it does go in for some sort of malunion, how much malunion is going to remodel and what type of fractures will remodel. We'll try to cover all these controversies and in the subsequent part. Non-operative treatment, which includes close reduction and casting, is a big chunk of cases big chunk of treatment in pediatric forearm fractures. So where do we do non-operative treatment? All undisplaced fractures in children go for non-operative treatment. That means casting. All green stick fractures are treated non-operatively, and most displaced fractures till the age of around 8 years or so are preferably treated non-operatively. So this is a general statement. Question is, why non-operative? So this, if you see this study way back in 1999 from the Journal of Paediatric Orthopaedics, they did about 300 close reductions and only 7% of their cases displaced. And out of these 22 or 7%, about 4% or 12 of them were treated again with close reduction and plaster using a little modified technique of pin and plaster. So that means around 95 or 96% of cases can be managed non-operatively. What are the principles of close reduction? For that, you need to evaluate the displacement. So if the radius and ulna are at the same level, there could be angulation, translation, or overriding if you have a situation like this, but no torsional
Excuse me,
component.
sir.
Sir, sorry
Sir,
to
your
interrupt you.
slide is not moving, sir. Your slides are not moving.
Sorry, I don't know. Okay.
Sir, first thing says full screen and then resume yourself.
Is it visible now?
Sir, slide
Yeah,
is
it's-
visible, but it's only one. Full screen and
I'll do it again. I don't know.
yes, sir. Please share.
Is it visible now?
Yes, sir. Yes, sir. Now it's
Yeah,
it
sir, it's
moving?
okay. Yes, yes, yes.
So
It's
do I
okay now.
start again?
yes. This is
Okay. So basically the presentations could be plastic bowing for pediatric forearm, green stick, complete or comminuted like this. These are some of the presentations of forearm fractures in children. You could have a non-operative treatment or operative treatment. And in operative treatment, if you choose operative treatment, again, there is a confusion regarding implant. And if you choose non-operative and if it does malunite, how much malunion should be acceptable in children? Which fractures are likely to remodel? So these are all some of the controversies which we are going to discuss. Are my slides moving, please?
yes, sir.
Yes, sir. Moving, sir.
So
Sir, yeah,
non-operative
again.
treatment should be for whom? All undisplaced fractures, all green stick fractures, and most of the displaced fractures till the age of 8 or at the most 10. Most, I'm saying not all, but most displaced fractures should undergo non-operative treatment. And non-operative treatment for undisplaced is basically cast in situ. For green stick fractures is close reduction and casting. And again for displaced is close reduction and casting. Why non-operative? Because if you see this study, it's a large series of 300 close reductions for forearm fractures. And out of that, only 7% displaced. And of these 7%, most of them, they were treated again with a little modified technique of pin and plaster. What are the principles of close reduction and how do you assess the displacements? If you have the radius and ulna at the same level, you could have angulation, translation, or overriding, but usually there is no torsional component involved. And if you have a torsional component, the radius and ulna fractures are at different levels. And in supination, the radius is usually at a higher level. In pronation, it's the ulna at a higher level. So if you have fractures at two different levels for radius and ulna, consider a torsional component along with the rest of the component, something like this. It does have it. You see, these are at two different levels. The question is, once you are doing a close reduction, how do you know in which position to keep the forearm? So best way is to see this. radial tuberosity there, and the radial styloid points 180 degrees opposite to that. So if you see the radial tuberosity, the styloid is 180 degrees opposite to that. So that will give you a clue to that. The second thing which averagely most people think is that in the proximal third, it is usually the supination, middle third, it's mid prone, and distal third, it's full pronation. So these are some of the things which people think about, because you need to align the distal fragment in relation to the proximal fragment. There are some casting principles which will help you to reduce the displacement inside the plaster, and usually the cast should be an above elbow cast. The cast should be remodeled with usually a ulnar straight border, and the cast index, that means the width of the cast in the AP plane and the lateral plane, should be 0.8. So it should not be a circular cast, but a cast something like a oval cast, where in the AP plane the width is more, and in the lateral plane the width is much less, and the cast index should be 0.8. So B over A should be 0.8. Sorry, A over B should be 0.8. So this should be the remodeling, where you just try to sort of create the intraosseous space as well. So you try to remodel along the intraosseous space as well. And once you do a close reduction, you should always do weekly check X-rays for minimum of 3 weeks and compare it to the immediate post-reduction X-rays. And if it redisplaces, then consider a operative fixation. Where do you see redisplacement? Loss of reduction is basically seen in much less in younger children, but much more in older children. Older means around 8 to 10 years of age. It is not a magic number. 8 years, you will see 7 to 13%, and after 8, you will see only more than 60%. But the basic idea is that the younger the child, the less is the loss of reduction. The older the child, the more is the loss of reduction inside the plaster. So which are the fractures which are prone for redisplacement as far as the fracture morphology is concerned? So if there is a pre-reduction translation, that means the fracture is translated. So they are prone for redisplacement. A non-anatomical reduction is more prone for redisplacement in plaster. Older child, and the more proximal the fracture, the more the chances of redisplacement inside the plaster. Now, once this there is a redisplacement, how much redisplacement or malalignment is acceptable? As a general rule, the more proximal you go, the less angulation and malalignment is acceptable. The more distal you go, the more angulation and malalignment are acceptable. So angulation averagely acceptable is around 10 degrees in the proximal third, 15 degrees in the mid third, and 20 degrees in the distal third. And usually the age should be less than 8 or 9 years of age. And more than that, this angulation is likely to create problems for the child. If there is a translation and a shortening of less than 1 centimeter, even 100% translation is acceptable. But usually minimum or no rotation is acceptable. So if you see this, there is a lot of rotational component. You see these are wide apart, these are overlapping. So there is a lot of rotational component, and this sort of reduction is not acceptable. Why this is not acceptable? Because if the angulation is more than 10 to 20 degrees, there is a loss of pronation supination, especially if the age is more than 80 years. And more so if the fracture is in the proximal forearm. So basically, to sort of summarize the things, the more distal the fracture, the more you can consider a non-operative treatment. the more proximal the fracture, the more you go towards a operative treatment. Why? Because the chances of displacement are much more in the proximal, much less in the distal. Second thing is, the older the child, you consider a non-operative treatment. And malunion, the more distal the malunion, the more likely it is to remodel, especially the angulation, but not the rotations. Why? Because the distal end is the growing end of the in a child. So if you see this case example of malunion, and you see there is a loss of pronation and supination, and the radius is, if it malunites, it will cause a loss of pronation, supination, and if the ulna malunites, it is likely to cause more of cosmetic issues. And if both malunite, there will be additive effect. The rotational malalignment is poorly tolerated and does not remodel. What will remodel is angular malalignment. And if you have a complete displacement with angulation, with malrotation, they all have an additive effect on the loss of pronation and supination. So where do you do a primary operative intervention? Unstable fractures, where you anticipate combination, unstable fractures, a failure of close reduction, all open fractures obviously have to be operated, and older child, more than 10 years or so, you can consider a primary operative intervention. So difficult reduction, older patients, more proximal the fractures, there should be a low threshold for surgery, and one should not end up in a situation like this with a lot of angulation and malunion, causing both a cosmetic as well as loss of pronation and supination. What operative intervention? It should be a closed reduction, or if required, open reduction and elastic nailing. Or in case of a child nearing adolescence, you can consider open reduction and internal fixation with plates, especially around 14 plus age group. What hardware? Younger child, length stable fractures like this without combination, elastic nails. So these are some of the case examples of elastic nails. I'm just going to skip this. In an older child and adolescents or length unstable, it has to be plate and screws, not elastic nails, because if you put elastic nails, this patient is likely to end up in non-union, hypertrophic non-union, as you can see here. So basically, to summarize, closed reduction and POP cast still remains the gold standard in younger children. Failure of closed reduction, loss of reduction in plaster should be treated with closed reduction or open reduction and internal fixation with elastic nail. Older child more than 10, consider primary internal fixation with elastic nails. Adolescents, consider primary surgery with plate and screws. So I think I'll stop here. Thank you so much. I'll stop sharing. So, Dr. Sirohi.
Thank you, sir. But I think that we still have some time for the.
So I can
Montessia.
take up Montessia and Galeazzi if it is okay.
Sir, I think you should take up because we have time, sir.
All right. All right. Can you see the screen, please?
Yes, sir.
So this is a case example of a 7-year-old boy had a plaster immobilization for soft tissue injury in the forearm, but still painful after 2 months. So what is wrong here? There's something wrong here which we'll be discussing subsequently. And this is the second patient with an 8-year-old girl with this sort of fracture. How will you manage? Let's clear some doubts in the subsequent talk. So I'll be basically discussing about Montessia and Galeazzi lesion in children. Sir, are my slides moving?
Yes, sir.
Yes.
Yes, sir.
Okay.
Yes.
So first we'll be discussing about the Montessia lesion principles of management. So how do they present and what are the principles of management of acute Montessia and how to avoid pitfalls in identification and management. So Montessia fracture dislocation, as I say, was described by Montessia way back to about 200 years ago. And it is a fracture seen in both adults and children. So it's a fracture of the ulna with the dislocation of the radial head with various combinations. But what I will be discussing today are the simple Montessia fractures. So if you see both the bones of forearm like this, they are intricately related to each other and held together by the proximal and distal radioulnar joints with their ligaments and the interosseous membrane as well. So if there is a force and there is an undisplaced fracture like a nightstick injury, so it's only one bone, usually the ulna, which is going to fracture like this. But if you have a larger force which causes a lot of displacement, both the bones, that's the radius as well as the ulna, will fracture. Because to displace, both the bones have to fracture because both the bones are intricately related to each other, proximally, distally, as well as to the interosseous membrane. But what happens if one bone fractures and it displaces, so and the other bone does not fracture? So it will basically lead to a dislocation of the radial head. So that is what is called as a Montessia fracture. And if there is a fracture of the radius and there is a distal radioulnar joint dislocation, that will be a Galeazzi fracture. So Montessia fracture in children depends on the force direction. So it is basically 4 types. Remember, the radial head can go anteriorly. So that is an anterior Montessia. It can go posteriorly. That's a posterior Montessia. It can go laterally. That's a lateral Montessia. It can go medially. No, it cannot go medially because there is the ulna there. So there is no medial Montessia. So type 1 basically is an anterior dislocation of the radial head like this with the anterior angulation of the ulna. So they constitute about 70% or more of the total Montessia lesions. So what do you do? It's very simple. You just have to reverse the deformity, that is, do a close reduction for the ulna and hyperflex the elbow. And once the radial head reduces back to the position, then you give a cast in hyperflexion. Why in hyperflexion? Because you have to give in more than 90 degrees because this is to neutralize the pull of biceps. Otherwise, the biceps is going to pull the radial head again into an anterior Montessia anteriorly. But if it is unstable, which you recognize on table, that if you leave the reduction, the radial head dislocates back, consider a internal fixation after a closed reduction or a open reduction, whatever you feel it is necessary. Type 2 are the posterior Montessias, which are very, very uncommon, about 6%. And there is a posterior dislocation of the radial head. How do you identify the dislocation of the radial head? Is by this radiocapitellar line. And if you draw a radiocapitellar line along the long axis of radius, it should bisect this epiphysis of the capitella. So normally a line should pass through the center of this. And if it passes anterior to this, then that is the anterior Montessia. And if it passes posterior to this, that's a posterior Montessia like this. And that is the capitella. So again, for type 2, you consider a closed reduction. Basic idea is to put the radial head in position. Once the radial head is in position, it is no longer dislocated or subluxated. Ulna, even if minor angulations are there, that's not going to matter much. So basically for type 2, it's traction in flexion and pronation, and elbow in either about 30 degrees of flexion or about 60 degrees of flexion, where you think this reduction remains stable. And if on table, if you by gentle movement, if it basically dislocates back, then you consider an internal fixation with K-wires, plates, whatever you think is necessary. Type 3 lesions are basically lateral Montesias, where there is a lateral angulation of the ulna. So they are potentially unstable fractures. So consider a closed reduction. If it is stable, do a cast. If it is unstable, consider a internal fixation. So how do you do is a varus force, and with lateral pressure on the radial head, you reduce it and reverse the angulation. But type 3, again, if you think it is unstable, you fix them internally. Type 4 are basically high Montesias, where there is a fracture of both radius and ulna, high up, and an associated dislocation of the radial head. They are less than 1%, so you consider intramedullary fixation of both radius and ulna and close reduction of this injury. How to avoid pitfalls? You have to recognize the atypical presentations where there is the same patient which I showed earlier. So this is a plastic bowing of the ulna. And how do you identify that? If you draw a line from here to here, it should be line which should be all along the ulna. And if there is a gap between the ulna and this line, then that is an anteriorly angulated shaft. And if you second line which you draw is this radiocapitellar line, which should have passed through this. So this indicates an anterior dislocation. So this is a plastic deformation of ulna. It is not to be missed. Then is another atypical presentation where there is a fracture of the ulna and a radial neck fracture. Again, these are difficult cases. I'm not going to go into the details of that. And third is in a very young child where you think this is only a fracture of the ulna and a displaced fracture of the ulna. Please remember, isolated fracture of either ulna or radius cannot exist if it is displaced. It has to be either a dislocation of the radial head or the DRU dislocation. So again, the radiocapitellar line is very, very important here. And ulnar straight border, this is also called Mubarak's line. So first carry home message is that isolated ulnar fractures suspected should always be suspected as Montessia lesions unless proven otherwise. And the crux of closed reduction or realignment is radial head reduction. I'll repeat, the crux of realignment is radial head reduction. And most of these fractures, they are treated non-operatively, but surgical intervention is required if they are unstable or if the reduction is irreducible. I think I'll stop here because we may be running short of time. I think we can skip the Gillespie if you feel like so.
Thank you, sir. Thank you for the nice illustration. And the take-home message is very clear that suspicion is the key.
Yeah.
We should
And
always.
the second thing which I wish to highlight is for the forearm. Most forearm in younger than 8 should undergo closed reduction. And if you do a closed reduction, weekly check X-rays till minimum of 3 weeks to see the displacement in plaster. And older child, you can start considering the closed reduction or open reduction and internal fixation, especially if the fracture is proximal or if it is irreducible. So that is the crux of the total presentation for forearm. And for Montessia, it is a recognition.
Thank you, sir. But I will also request the panelists if there is any doubt and you want to ask any questions or clarify, please feel free.
Gupta sir, Dr. Saraswati here.
Yeah.
Sir, very lovely presentation. I think all the important points you have put across. Just one query I have. Sometimes there is a doubtful or query compartment syndrome. That is, there is some amount of swelling in the forearm, and child is still younger. So, and we cannot put a very tight cast. So we, when even we plan a closed reduction, is there a role, especially in this, because these days children are a little more obese and they have a quite a thick, bulky forearm. Is there a role of fixing one bone internally and putting a slab which keeps the reduction maintained? I mean, are there any?
See, technically speaking, yes, you can consider, but once you are operating, then it is better to fix both the bones. I mean, yes, people have been doing it in and out, fixing single bone and relying on the splintage effect of single bone with a, but
Yes, sir.
I mean, there's nothing right or wrong here, I would say. But my take home from this would be that if you're fixing one bone, why leave the other bone? Fix the other bone as well, because anyway you're operating.
Correct. Yes. Now this is a retrospect because one of the child where I managed close reduction, still there was a doubt whether the child is having a compartment syndrome. You know, it's very difficult at times. Children are fussy. They keep moving the fingers. You know, clinically it is not, but then they still complain of pain. So you have sleepless night till the swelling subsides, and that way.
I agreed. I think in such cases, if you are suspecting a swelling, or if there is a swelling, you can perhaps put in a slab for a day or two and then consider a close reduction later on. Or else, if it is a very chubby child, again, you can consider a primary internal fixation if it is a very, very chubby child.
Thank you, sir. Thank you.
Yes, Dr. Chetan.
Good evening, sir.
Good evening, Dr. Chetan.
Sir, my question is regarding the management of very distal fractures of the both forearm bones. So most of these fractures, we do a closed reduction, and then after 1 week or after some time, when 1 week, 10 days, when the child comes back, we see that the fracture has displaced. So what is your take over then? Most of these fractures, they are displaced in the anterior posterior plane only. So then after 1 week, what do you suggest that we do? Now, there is a little bit of angulation and the parents are just a little more factful.
So good question. So basically the question is that if you see an angulation or a little displacement at 1 week, what do you do?
Yes,
it's a
because
question
we
of
know
how
that
young.
these factors, they have a tendency to remodel also. But
So the issue is that it depends on how young the child is. If it is a very young child, and if it is only angulation, they tend to remodel. So very young child at 1 week, acceptable angulation, I would still continue the plaster. Unacceptable, I would remove the plaster and consider a operative fixation. Right. Best way is, once you have done a closed reduction, just gently move the wrist up and down. And if the fracture remains stable, it's likely to remain stable. If it displaces, then you have to be more careful. And this is true for even Montessia also. Just gently move the elbow up and down, and if it remains, it is likely to remain stable.
Okay, sir.
Sir, one question from my side also.
Yes, sir.
Sometimes the distal fractures of the forearm, the fracture is irreducible closed. So sometimes we use a joystick and a small artery forceps in between the segments. So they come back and then it becomes stable. So is it correct to do that, or it should not be?
Sir, there is nothing right or wrong, I would again say. If you can achieve a close reduction by joysticking, you can achieve it. However, you must, if you are doing some sort of intervention in between, you must be very sure that this fracture will remain stable. So gently move the wrist up and down, gently move the elbow, right? And if you feel that it is not displacing, you can continue with the plaster. Otherwise, if you are just, I mean, if you are intervening with a joystick, and if it is unstable, it is better to fix internally.
Okay.
That would be my
Yes, Dr.
rational
Mittal, sir.
thinking.
Can I ask one question?
Yes.
PN, today, how many attempts would you allow for manipulation? Suppose I don't get a correct reduction in first attempt.
Yeah.
Am I allowed to do a second or
Yeah,
third?
2 attempts at the most.
How many?
Under general anesthesia.
Okay.
Like lot of places, people tend to do under sedation, where the child is not relaxed. So it has to be under a proper anesthesia. And then you have the Siam, and I think most of the hospitals will have a Siam. And best is if you achieve alignment, see if it is stable, and consider a plaster. Not one attempt not successful, second attempt you can in the same anesthesia. Not successful in the same anesthesia, consider a operative fixation.
Okay. And if the fracture redisplaces in cast,
Yeah.
Is remanipulation advised or straight away surgery?
Again, I would say there is nothing right or wrong here. It is your choice whether you want to consider surgery. I would consider surgery. Why? Because the fracture has displaced in the plaster. It has a tendency to displace. And I would be more secure by internally fixing it. But people have done closed reductions again, as I showed in that article.
Because when we were taught as residents, they said when the swelling decreases,
yeah,
the reduction, the cast becomes loose.
Yes.
So there's a tendency to displace, and then you re-manipulate and
you
actually
can do that
in our residency.
Sir, you can do that. It's absolutely, there's no problem in that. It depends on center to center. A busy center like yours or busy center like mine, you know, it's very difficult for the patient to go across to a doctor. So sometimes they get totally lost in the follow-up. So I would be more comfortable fixing it internally rather than not. But yes, if there is a center where you can call the patient repeatedly, you can still consider a close reduction.
So if there is no question, we should move.
Can I ask, sir, one question to Gupta, sir?
Yes.
Yeah. Distal forearm fracture is only fracture of the radius or ulna, something as the discussion is going on. So as sir's talk say, we can see the acceptable reduction in pediatric most of the time. You know the very good remodeling potential there.
Yes.
You know, you are the operating surgeon, you are treating the conservative. What should be accepted? You have the courage to face the consequence, discuss with the parent, because most of the common scenario after 3 weeks, at Dr. Chetan said, after 4 weeks you reduce the plaster and the parent complaint there is a angulation at fracture side. So acceptable criteria, age of the child is very important to decide. So once you do the post-op X-ray, as sir suggests, cast index is very much wrong. My suggestion, if you need isolated fracture, distal radius, ulna is intact, the more chances of the redisplacement after a week. That situation you can ideally fix. Chubby child, more age, you can treat operatively. You have to see the X-ray fracture pattern and decide.
Agreed, sir. Fully agreed.
Yes.
Fully agreed. What I would do is whatever, you know, gentle manipulations you can see on table, and if you feel that this fracture is sort of trying to go in for a little instability, you can consider a closed pinning or closed reduction and intramedullary, whatever the fractures, whatever the fixation is suitable.
So thank you, sir, for this nice discussion and clearing of the issues. I would request Dr. Mittal, sir, to please share his screen and start his presentation. Habitual dislocation of patella, 2-in-1 procedure.
Good evening, everybody. Can you hear me?
Yes, sir.
Thank you, Dr. Sirohi, for this invitation. And I'll be speaking about habitual dislocation patella and emphasis on 2-in-1 procedure. Now, patella is one bone which traverses in the trochlea of the femur. There are forces on the supromedial, inframedial, supralateral, infralateral, superior and inferior forces. So there is a balance of these forces which allows the patella to stay within the trochlea in all range of knee flexion and extension. Now, habitual dislocation patella is when it dislocates with every flexion movement and relocates spontaneously with every extension movement. So this is a typical case of habitual dislocation patella, where it dislocates on flexion and spontaneously reduces on extension. This is dislocation of patella, and then it reduces in extension. And it happens every time the patient bends his knee or extends his knee. Now, when you look at the pathology in habitual dislocation patella, the lateral structures are tight. The retinaculum on the lateral side, vastus lateralis, and there are tight facial bands between the fascia and the patella. There is a lateral rotation of the whole quadriceps mass, and there is shortening of the quadriceps. And the medial structures are deficient medial patellofemoral ligament and vastus medialis. Additional bony pathologies can be there, like trochlea hypoplasia, patella alta, genu valgum, increased femoral anteversion, and external tibia torsion. Treatment for habitual patellar dislocation is surgical. I don't know if any conservative treatment has been described. I'm not aware of that. And if there is any bony problem, like any torsional or angular deformity, we have to correct that first. And then if the remaining problem is there, then we have to do a soft tissue surgery. And if there is no torsional or angular deformity, then we have to do a soft tissue procedure and balance the vectors which are acting on patella. And historically, many procedures have been described for habitual patellar dislocation, and there is no consensus what is right and what is balanced procedure for this problem. And to balance the vectors, we have to release the structures on the lateral side and decrease the vector force on the lateral side. And we have to increase the vectors on the medial side by either ligament reconstruction or distalization and lateralization of vastus medialis. So this was a paper that we published by us, where we did a modified 4-in-1 procedure. We released the structures on the lateral side, the lateral retinaculum and the lateral half of the patellar tendon. On the medial side, we did a lateral and distal advancement of the vastus medialis and reconstructed the medial patellofemoral ligament. And it gives us very decent results, and patients are happy. No problem with that. But the other procedure could be that we just release the structures on the lateral side. We lengthen the shortened vastus lateralis and the quadriceps and shift the whole quadriceps mass, which is shifted laterally, to its central position. So this is another way of balancing the vectors by operating only on the lateral side. So that's our procedure that we described, that we do surgery only on the lateral side. We release the lateral retinaculum. Vastus lateralis is released from the lateral intermuscular septum. We do lengthening of the quadriceps by fractional lengthening. And we also release the lateral half of patellar tendon. And we do all these steps proximal to patella and distal to patella. And we don't touch the medial structures at all. That is why we shifted from 4-in-1 to 2-in-1 procedure. So the case that we select is usually a child, and this child has open growth plates. So we don't do anything to the trochlea or the tibial tuberosity because the growth plates are open. And we have to rule out genu valgum and the torsional deformity in tibia and femur before we proceed with these procedures. So we do a midline anterior incision without a tourniquet, and I'll be showing pictures from two cases. So don't feel that this picture is not from this case. So this is a big incision. This is the proximal end and this is the distal end. We give a midline anterior incision and isolate the quadriceps mechanism, extensor mechanism. And this is the tight iliotibial band that you are seeing, and this is the quadriceps muscles. We expose like this. This is from another case. We release the vastus retralis from the septum. So this is the vastus retralis, and this structure is the lateral intramuscular septum. So we release the vastus retralis from the septum, and we dissect almost up till the mid-thigh. We release the vastus retralis from the femur also, and we cut the thickened anterior periosteum of the femur like this, almost transversely. We come down distal to the patella and release the inferior retinaculum. So this is the release of the inferior retinaculum. And we almost always find thick fibrous band going from the lateral side of the patella or the patellar tendon, going towards the bone or the iliotibial band, which is there. So we isolate it and we start cutting it. So this picture can show you how thick this band can be on the lateral side. And this is after complete release. So then we proceed with the release of the lateral half of the patellar tendon. We give the incision vertically and then detach it from the tibial tuberosity. So what we do with that lateral half, we shift it medially and fix it to the soft tissue structures on this side. This is nothing but Roux-Goldberg procedure, which is a time-tested old procedure. And this medial transfer of the lateral half of the patellar tendon is possible only if you have released the retinaculum and the tight fibrous bands. Before that, if you don't do that, it's not possible to shift it medially. This picture also shows, I don't know whether you can see it or not. This shows the lateral division of the patellar half tendon. Then we proceed with the frictional lengthening of the vastus lateralis. We bend the knee, identify the tight structures, the tight bands, and do frictional lengthening. And we don't divide the whole thickness of the tendon. We progressively flex the knee and then find the tight bands and cut it. And you see that it's not located properly in the trochlea, it dislocates laterally. So we evert the patella and start doing frictional lengthening of the rectus femoris and the vastus intermedius.
I'm not cutting in full thickness, yes, sir. Partial thickness at 2 plexus.
So we never cut it in the full thickness, only small partial thickness cuts are made.
Okay.
And then after this, we can see that even in the flex position, the patella is centered in the trochlea and it doesn't dislocate. And we don't close anything on the lateral side. We suture the lateral half of the patellar tendon to the medial soft tissue structures, and we give a splint in flexion to relax and elongate the quadricep muscles for 2 weeks. We give a slab like this. Our usual average time is around 60 minutes to operate. We don't use any tourniquet and no blood transfusion is required. An average stay in the hospital is around 2 days. We remove the splint around 2 weeks and start knee movement. And we also start quadriceps strengthening exercises. What we see is that the range of motion is not decreased at all in this procedure. Patient can do straight leg raising in around 3 months. And we haven't had any redislocation till now, no infection. And this patient can walk, run, play, and squat without any dislocation of patella. And he is as good as any other child. So this is our post-op around 8 months old. You can see there is no dislocation of the patella. With extension and flexion. From the lateral side, also you can see that there is no dislocation of patella on flexion. The only problem with this procedure is the hypertrophic scar that we see often in these kids. Sorry. They're able to squat without dislocation. So what happens in long term? We see that there is remodeling of the trochlea, and because the patella starts moving normally in the trochlea, and whatever dysplasia is there, it's all remodeled once the patella sits over its normal position. To summarize, it is usually a child who presents with us and has open growth plates. So difficult to do any procedure on the tibial tuberosity or the trochlea. You usually have to do a soft tissue procedure. And before we select the procedure for the patient for this procedure, you have to rule out angular and torsional deformities. And we release soft tissue structures only on the lateral side. And no medial side is repair is done, no MPFL repair or advancement of the vastus medialis. This surgery is very easy and it uses no implants, and it has given good functional outcome to our patients. Thank you very much.
Thank you, sir. Thank you, Dr. Mittal.
Thank you,
And I
sir.
am sure there must be many technical questions in the audience as well as panelists. So it is open for discussion.
Yes, sir.
Nice techniques are actually what we have traditionally learned is the 4-in-1 technique, which already you have told.
Yes, I used to do it in the past, but then shifted to this procedure.
Yes, sir. So I have also experienced of about 4 or 5 cases of 4-in-1 technique. This has given a good result in shorter term follow-up. We also, sometimes tried that let's not disturb anything on the medial side. But what we found was our kids were actually a little younger, 3 or 4 years of age. So what we found, unless we do something on the medial side, like most commonly we do tenodesis of the semi-teaser. So without doing it, it is a little bit unstable. So how will you address this thing? A little bit of laxity.
Okay, I'll tell you my transition from 4-in-1 to 2-in-1. Now, since I was doing 4-in-1, I kept on doing it. And one day I was doing 4-in-1. I found that after my release on the lateral side, I could balance it without doing anything on the medial side. That's how I started doing it. So what I find the difference between 2-in-1 and 4-in-1 is that you have to give a slightly longer incision in 2-in-1 procedure. Your release of the vasa laterales has to be more extensive. Distal release is almost the same in both the procedures. And once you have done that, you start flexing your knee, keeping patella in trochlea. And once you start bending the knee, you will find some tight structures on the lateral aspect of vasa lateralis. So as I showed you, so you start cutting them with a cautery, with what you call fractional lengthening. So you don't cut full thickness, just partial thickness, multiple places. And at times, this is not sufficient. So you evert the patella, which is very easy when you have released the quadriceps. Now you have to release the periosteum also, because that has got adhesions between the femur and the quadricep mechanism. So you have to release the periosteum. You cut it transversely because that lengthens it. Adhesion between the suprapatellar pouch and the quadriceps are also to be released. And then you do fractional lengthening on the under surface of the quadriceps tendon, the whole tendon. Very superficial at multiple places. And you just have to titrate it. You have to be patient. And you will just see that at one point, you start flexing beyond the 90 degrees and it stays there. And if it starts staying there beyond at 90, you will slightly flex it more, keeping your finger just on one finger on the patella, and you will see that you can flex more and more. The quadricep mechanism stretches out, and you can hear some crackling sound at times, which does not break the quadricep mechanism, but it just lengthens. You know, it is something like a fractional lengthening of TA. So once it's there and once it stays there, around 120 degrees, it stays there. It just stays there.
Dr. Ravi, one question and one comment.
Yes.
Question is, do you close the lateral synovium?
No.
You don't close. Okay.
No.
Now, one comment is that I have done a lot of habitual dislocations of patella. I do the way is almost similar, but I plicate the middle side as well. But one observation which I have is the moment you place the patella into the trochlea, you can see the angle between the quadriceps proximal to the patella and the patellar tendon sometimes goes to around 60 or 70 degrees. So I do it the way you do for the distal realignment. Proximal, I'll do it like a little differently, but not much differences in the technique. I do a distal release of the lateralis rather than lifting from the septum. So, but these are subtle differences. But what I have found is that the distal realignment is almost always required. Almost. I've never had a patient where I did not require a distal realignment.
So, Dr. PN, we have done a distal realignment. We release the lateral structures, release the lateral half of the patellar tendon, the root goal with.
Yeah, I do it the same way how you do it.
Now, when you do a medial reefing that you described and you see an angle of 60 degrees, it is because the whole of quadriceps has rotated on the lateral side.
Yeah.
And it will come back to its normal position only when you release it more extensively on the lateral side.
Yeah, I agree.
You release it from the septum and you have to release it from the femur also.
Agreed, sir. Agreed.
And once
I agree, but what I'm trying to say is I do it a little different than what you're doing.
Yeah.
But distal realignment is always required.
Yeah. See, I'm also doing it. So I'm doing everything proximal and distal to patella.
Yeah.
Everything on the lateral side and nothing on the medial side.
Okay.
Okay. So I'm not reconstructing the MPFL.
I'm not reconstructing the MPFL, but just doing a little plication sometimes.
No, I'm not opening that side at all.
Okay.
Okay. So that's the advantage that I get. The only problem that I have with this procedure is that the scar becomes hypertrophic and disfiguring. And
Especially distal to the patella.
distal to the patella, at times proximal to the patella. And the only complaint that the parents complain is about the scar, nothing else. They are very happy with the function. But when you do fractional lengthening of the quadriceps, obviously there is some weakening of the quadricep mechanism. And it takes around 3 months to have a straight leg raising. Before that, the patient cannot do straight. And after that, the recovery is very fast. And by 4 to 5 months, they are running, playing, and jumping, everything, doing everything.
Agreed, sir. Agreed. Same results here we have.
So I have one question too.
Yeah.
So as you show your post-op X-ray, you are given more than 120 flexion.
Yeah.
So it is your routine protocol. Is there any wound problem after giving 120 flexion? How many days you will give the same slab? Because we face sometimes we'll give more than 90 scar days or so. So any tricks for that?
2 weeks.
2 weeks. So no wound problem with hyperflexion?
No.
Okay.
No.
Yeah. So all the patient in your paper is a skeletally premature. Same patient, if the skeletal growth is over, so you will follow same, or you will just, as PN Gupta sir say, distal alignment is very important. Sometimes you will transfer the tibial tuberosity for more stability.
I have done only one patient, which was post-infection on the lateral side. So there was scarring on the lateral side. So I just released those scars and did the same procedure in a skeletally mature patient. I have experienced only one. I know one case would not be enough for you to say yes or no.
Can I add something? Even for an adult patient, I would still consider transferring the lateral half of the tendon medially, even in adults.
Yeah.
I mean, I have had such a good result in children.
No.
That
in that adult patient, I transferred the lateral half of the patellar tendon medially. Exactly the same way I've been doing for, but I've done only one adult patient, rest all have been children. One thing about the closure. Now, when you're closing, we leave everything open on the lateral side. So, and we just close, we don't close the deep fascia at all. We just close the superficial fascia, subcutaneous tissue and the skin. So at times, when you take a bite, it might be too tight and the patella may dislocate laterally. So when you're closing in flexion with the patella placed in the trochlea, and when you close the subcutaneous tissue, you always move the knee flexion extension and see that your closure is not tight. So at times I had to just cut some sutures and redo in a loose fashion so that my closure is not tight and patella does not dislocate. So closure of the subcutaneous tissue is also important in this case.
Dr. Ravi, just one small comment which Dr. Jaideep said is that if you perhaps try and reduce post-operative flexion to a little lesser degree, maybe the scar could be better. I don't know, just a thought. So that is actually stretching the tissues, and if you could reduce the flexion.
Yeah, as we have faced the same problem after giving hyperflexion, the one day is a hypertrophic scar. One more question. So, lot of literature is available on habitual dislocation.
Before you ask me the question, can I say something?
Yes.
Yeah.
I never had a problem of wound dehiscence. The scar becomes hypertrophic in the follow-up period after suture removal. There is no problem of wound healing at all. The skin never gapes. It heals very well. But it just becomes hypertrophic later on. And I have been giving some local steroid ointments, some coconut oil, and I've been managing with that only. But still, it poses a problem for the parents, not for the kid. Yes, please go ahead with your question.
Okay. Dr. Jaideep, you're asking. Sir, I have one question. If there is an associated angular deformity like a genovalgum, is there a role for 8-plate application along with this correction? Do you do that? I mean, has there been cases where you had to do a 8-plate along with this?
My thumb rule is when there is a combination of a soft tissue and a bony pathology, I always do bony pathology correction first. and I will wait for some time and look how my results are going and do soft tissue pathology later on,
Okay.
soft tissue correction later on.
Okay. So with the habitual dislocation and genu valgum, though it is habitual dislocation, if you don't plan to do it at the same setting, right, sir?
Yeah, I have done only one patient of, say, a teenager, skeletally matured patient with genu valgum and habitual patellar dislocation. I did a distal femoral osteotomy only.
Okay.
No soft tissue release, and there was no dislocation.
After the correction. Okay.
Okay, so I don't do any, I don't combine soft tissue and bony procedures.
Okay.
I do bony procedure first and let me see. That's what I do.
Yes.
Sir, in your record, no MPFL reconstruction done in any patient?
No. In 2-in-1 procedure, no. That's what I want to say, that you can flow against the tide also at times. In adults, orthopedics like sports medicine, MPFL is a big rage. There is no sports medicine or arthroscopy surgeon who doesn't talk about MPFL, and they swear by it. And the same thing has coming down to pediatric orthopedics also. Pediatric orthopedicians also reconstructing MPFL left, right, and center. Even doing bony fixation of the ligament on the femur under image intensifier to protect the growth plate. So I'm showing you no MPFL. So this is just flowing against the tide, but it's there for you to see.
Thank you, sir, for your nice technique.
Thank you.
Thanks, sir. I think, sir, I would ask, was your follow-up long enough, or did you see any relapse?
No relapse, sir.
No
So
relapse.
what happens is, if your patella is not dislocated for say 4 to 6 months, it will not dislocate later on. Moreover, the trochlea will remodel according to the patella. So whatever displaces there, it remodels. I have not shown in my studies, but other people have shown in their studies that once the patella is dislocated, the trochlear dysplasia also improves to a normal pattern. Though it is mainly cartilaginous, but they have shown that it improves. So if it is not dislocated for 4 to 6 months, it will not dislocate later on.
Thank you, sir. So I would request Dr. Jaideep Dhemele to please share his screen.
So my slide is visible?
Yes, your
Yeah.
slide.
So thank you for the opportunity. Just talking of the lower limb trauma, basically fracture femur in children, as I discussing the cases. So it is the third most common lower extremity fracture. 1.6% children sustaining the fracture. Prognosis is usually good due to high bone remodeling potential in children. Non-operative treatment is the gold standard less than 6 years of age. The most common complication for sharp fracture is limb length disparity, either shortening or lengthening. So we just go from the history. If you see the from past, Egyptian who just treated previously fracture sharp femur with just wooden stick. This is a bony model from the mummies. Then 1855, they just plaster impregnated in fabric strip. Then Professor Thomas, who just devised the Thomas spring, then started using the Thomas spring. Then Moose and Sharper in 1948 fixed with his spica casting for pediatric femur fracture. Then Demerson and Thompson 1957 spica casting application for short-term outcome. Then after that, elastic nail, Enders nail, everything is developed. So ideal treatment of the fracture sharp femur in children is that when we control the alignment and length, it is comfortable for the child and convenient for the family. The causes is the best least negative effect, psychological impact, and possible results. So whenever you are deciding the management of the fracture sharp femur, you always see the length, stability, and just avoid the deformity after the once the fracture is healed. So here is acceptable angulation. You must know what are the acceptable angulation from birth to 2 years. 2 to 5 years, 6 to 10 years, and 11 years to maturity. As the age is advanced, there is a very less margin of acceptable angulation and shortening. So we have lot of option for treating the pediatric fracture. So just for soft immobilization, we have the Paulik harness, brace. Hard immobilization, we have the spica, traction, intramedullary nailing either by the elastic nailing or rigid, just like Enders nail, plate, X-fix, or combination of X-fix and tense nail. So there are the AOS guideline is available for pediatric diaphyseal fracture. So we just go from case by case here. The neonatal fracture here. This case one, neonates with the right thigh deformity. I would like someone just comment how will you treat such here. Sirohi sir, what is your opinion? This is a neonates with right side fracture femur. So option here, whether you'd like to give gallo traction, Bryant traction, mid spica, Paulik harness, or strapping of the thigh to abdomen.
Gallows.
Gallows.
Paulik harness is good.
Okay. Anyone else?
Yeah, I'll also like a Paulik harness.
Okay.
But D is also good. Strapping of thigh to abdomen.
Strapping of thigh we can also do.
So
But
because
harness is a comfortable thing.
Okay, because these are all the option everywhere, all over India, or just following also. One say gallows, one says Paulik, one other says the strapping. So these were treated by the hip spica. So anything comment? What is the position of spica here? This spica is acceptable for neonates?
No, for neonates, not.
It's not at all, sir. I don't think so.
Okay.
Jaideep, can I add something?
Yes, sir.
So basically, spica is very, very cumbersome for a tender skin in a small neonate.
Yes, sir.
And if you see the natural, go back please to the, if you see the natural tendency of the limb in a neonate or within first 3 months or so,
Yes.
is a natural tendency of flexion.
Yes, sir.
So that is the position what the person is inside the womb. So you have to flex the distal fragment, and that is best achieved by Paulik harness.
Yes, yes, sir. So this child is presented to us after that because this is a spica given. So you can see that 15 months age. So fracture is united, but there is angulation. You can see there. At the 15 months of this angulation acceptable. Is almost 90-degree angulation here. So as previously you say the spica is given in extension. If the spica, not ideally, if it is given in flexion, it may be united better position. So as P.N. Gupta sir says, ideally it should be Paulik harness. So you can see here the child is still small, he is walking, no complaint, but will not accept. We just keeping this child observation. Because right now they have no complaint, he's absolutely walking, but he require in future some intervention. After observing also 6 to 8 months, almost 80-degree angulation is still there. So as you know, the proximal femur will grow 30%, distal femur will go 70%. So it will not remodel. We are closely watch on this child. So this you can see the here as previous slide. So we can go the same fracture on opposite side. Now, what are the options? As we have seen, what went wrong in first case, the same case.
This is the same child.
No, this is the second case. So first has a same fracture on opposite side. This is on other side. So this previously treated by the spica. Now you have the first case in. Now this is the second case. So you have better. We have everybody say Paulik harness is good. So now this is the case. Here you can see the same fracture.
Paulik harness would be
Paulik harness. Anyone for Bryant traction? So maybe our teacher previously at medical college treated with gallows or Bryant traction. So this is a gallows traction. This child is treated by the gallows traction. The problem with the gallows traction in pediatric is associated with a lot of complications, just like a skin problem. In rare cases, there's a compartment syndrome is reported in literature. So nowadays we are not using any gallows traction. So mainly using Paulik harness. So Paulic harness is the gold standard for the neonate fracture. It will still remodel. As Gupta sir suggests, we have to align the distal fragment compared to proximal, because proximal is the flexion and external rotation of the fragment. You just align the distal fragment with Paulic harness, it will remodel. This paper can show the long-term effect. Angulation is corrected. He has developed the procurvatum, then valgus, and at the 6th year, the fracture is completely remodeled. So this is the Paulic harness. So after treating the Paulic harness for first few weeks, for few days, the child is irritable. Then he can settle down. For additional, sometime we can use the lateral cupboard support to immobilize the femur. So this was treated with Paulic harness 4 weeks, 1 year. Then another case, neonate with the bilateral fracture femur, neonates only. So basically, this is case of orthogryposis multiplex congenita. Here is the bilateral femur fracture, difficult case, bilateral knee in extension contracture, hip in extension contracture. So I can ask Dr. Chetan, anyone can, we can treat same with the Paulic harness here. It's neonate.
So now he has arthrogryposis, so I don't think we will be able to treat him by this Paulic harness.
So I am showing the neonate 3 different types of cases. Everything is managed differently. So same option here. So it is as say it is AMC child, we have to treat with the spica. No other option is available. Gupta sir, any suggestion for this case? AMC child, everything is tight. So spica given is also difficult. Dr. Saraswati, any comment?
So can I make a comment?
Yes, sir.
Yeah. Basically, all these fractures in a neonate, they're eventually, I mean, most of them, they will remodel with passage of time.
Yes.
So the idea is to actually splint them till they unite. So with the arthrogryposis, with the limited motion, I would consider sort of a splintage using cardboard, because Paulic harness may sort of lead to a lot of deformity further, and
Yes.
the child may take a long time to sort of remodel. So this is like little different from the regular fracture. So I mean, perhaps my choice would be just a simple cardboard.
Yes.
Yeah.
So we have treated as a spica, as sir says, basically here is we just want immobilization. So fracture femur 6 months to 6 years. So as I previously said, the AOS guideline. So we suggest early spica or traction. Lot of debate is on literature. Should we give day 1 spica or give the traction or give the tissue splint? Then we convert into the hip spica. 4 case, 4-year-old child with fracture femur. You can see here the length unstable fracture, overriding is there. So we just go with, I have the option traction, Thomas splint, traction followed by the spica, immediate spica, TENS or X-fix.
So I would like to go for the traction followed by spica.
Okay. Traction, how many days traction?
1 week or 10 days maximum.
What type of traction you will do?
Skin traction, where I'll try to keep the limb aligned.
Unilateral, bilateral?
Unilateral will be okay. The counter traction.
Any other opinion?
Yeah. I'll just try to be, I mean, basically the traction is not for a particular number of days actually. What you see in the traction is, this is a situation which is a little unstable.
Yes, sir.
So the traction is to keep the things aligned.
Yeah.
I would consider a traction here. I mean, if you see the literature, they can you can still consider a primary hip spica because the initial overriding is much less. They're less likely to override in future. But my choice here would be traction till the fracture becomes sticky enough. Sticky, how do I define sticky? Is that once you sort of gently take the traction off, there should not be a lot of angulation at the fracture site. So once this movement at the fracture site reduces, I will just put in a spica without anesthesia.
So yes, sir.
That would be my choice. However,
Yeah.
as I said in the literature, with this much of overriding, which is about less than a centimeter, you can still consider a hip spica.
So here you can see the butterfly overriding as is
Yeah.
more also. There is a unstable. You can see the
Unstable.
telescope.
That is what
unstable.
I'm saying. My choice
So,
would be traction followed by spica.
yeah. So at Dr. Chetan says 1 week of traction. So as you say, sir, the gummy. So it will take at least 2 to 3 weeks minimum for 4 years of the age.
Agreed, maybe around 2 weeks or so.
Yeah, 2 to 3 weeks. 1 week is less time.
Agreed.
Yes. So this was treated with we have treated with the Thomas grip. Basically, we want to maintain the length. This looks okay here.
Yes, it looks okay.
Anyone wants anything to view? Because this is on TT screen, you see everything is fractured, distracted, length maintained. After 3 weeks, you can see that there is angulation. So we'll accept this, manipulate, nail, or we do the spica here. I'm taking slower time, just wanted to know everything. So sometimes the patient may present at 3 weeks. Some primary surgeon has treated and then patient went after seeing these X-ray for second opinion.
So I wanted to ask you, why did you manage him in a Thomas print definitively? So 3 weeks is, I think 3 weeks is a for in a patient to be in Thomas print, that is going the traction will loosen up and there will be some displacement. So I will probably do a spica cast after 2 weeks when the fracture gets little sticky. What was the idea of managing him in a Thomas print for 3 weeks?
So as we say, we just wanted the length. Okay, so 2 weeks is too less to give spica or something. So we just wanted to maintain this. The child is presented to us is late. That's why I'm telling you. So these are the cases we have collected. Those who are presented early or late. So this we are treated with spica. You can see at 2 months there is a nice healing, but angulation. You can see 45 degrees angulation here. So treatment option right now at 2 months. So osteotomy plating, osteotomy nailing, we can wait and observe still because in APs look good. On lateral, you can see almost 45 degree angulation. So with less of time, I can go just forward. After 2 years, you can see the fracture is nicely from angulation 45 degree, it's reduced to 30 degree. On APs looks very good.
No, Dr. Jaideep, I wanted to ask, so in this case, the angulation seems to be acceptable. So, but what do you do in a case where like you are up with a surprise like this case only? So after 1 month, the patient comes back and you see that there's a lot of angulation, like angulation like 60 degree or 50 degree. So what would you like to do in that case?
Still we I will manage every 3 monthly or 6 monthly to know. Basically, we just angulation will correct. So you have to see the clinically and radiologically whether it is a malalignment, rotational alignment. Rotational alignment will require some intervention, but angulation we can wait, we can observe because functionally patient is doing better. So you can over the period of time the angulation is almost remodeled. If simultaneously he has the mal rotation, as previous forearm fracture, mal rotation we cannot accept. Shortening, LLD, displacement, anterior posterior we can because less than 6 years, lot of potential to remodel. So that's why we just observe. So another case, 3 years old child with fracture sharp femur. So here, telescopy, lot of overriding. So same option. So here we have treated with spica. Post-op X-ray show the overriding is too much. You can see here So any option here? So someone can reapply the spica, some can, it's a 4-year child. Someone can do the nailing or any other position, or what went wrong here, or any other alternative option.
Elastic nailing.
Any other option, sir? So we have treated here. So we have done the wedging. Because in CP we do the lot of wedging to correct the knee deformity. We have done the anterior wedging here. You can see here X-ray also. So we'll just give some comments on the how to give the hip spica, not details, because a lot of confusion about the hip spica. So ideally it should be 45, 45, 10 for proximal, middle 30, 30, 10, 20, 20, 10. Location of fracture as literature suggests. So previous case after 7 weeks, you can see here. Here is a shortening is 2 centimeter. So remodeling is going on. You can see in 2000 already equal length as previously 2 centimeter shortening. Both the femur are equal. So these are the systemic review for spica casting for children less than 6 years. So I'm going an acceptable shortening. So lot of literature say ki fracture femur. So you have to see first post-op X-ray. You know whether it is going to lengthen or it is going to shorten. The acceptable shortening is 17 mm to 18 mm. More than 10 years, 12 to 14 mm till the age of the puberty. This graph shows how much shortening you can accept. How much varus or varus or valgus angulation. As the age advances, there is a very little margin to accept the varus valgus angulation. Sagittal angulation better tolerated than frontal. So here I'm showing another case, older child, 6-year-old child with fracture femur, treated with TT spin for 1 week. They just presented after 1 week to us with this picture. Same option. So we have continued the sprint for 3 weeks, and then we have started giving the single leg spica as the fracture is gummy. So this is a very good. Someone can see the walking spica cast from Posna website. So patient are very comfortable. After 3 weeks, you can allow, they can walk. You can see after 1 month, 3 months, very good remodeling. She is walking. Another case, you can see here, 6-year child with fracture femur. Shortening is more than 5 centimeter on telescopic test. So same option. I'm just running fast because treated with Thomas splint, followed by spica after 2 weeks. You can see here 25-degree angulation, epilateral view, 4 mm shortening. So these are the different cases, how we can manage and how can we just avoid the complication if we know the potential of the remodeling, what to accept and what not to accept. So here another case, she is a 4-year girl child with sustained bilateral sharp fracture femur in road traffic accident with pubic fracture and hematuria. So now as previous cases say up to 6 years, so gold standard is traction or immediate spica. We have seen the cases. Now here bilateral fracture with pelvic injury with hematuria. What are the options? Immediate spica, XP, Thomas splint, TENS or plating. Sir?
So she is having polytrauma, and as you said that she has hematuria also. So
Yeah.
I don't think spica is an option over here.
Yeah, but she's hemodynamically she's stable. Only pubis symphysis is fracture, but she has a hematuria. But as considered age, so we have treated with close reduction bilateral TENS. Bilateral fracture, pubic injury, that's where I put the skin traction also simultaneously. So this is a post week, here 1 year follow. And at the age of 16, you can see both there is no limb length disparity, almost 11-year follow. So another case, 7.5-year male child, he almost follow up with us after 6 months of injury. This is the X-ray, first X-ray. Someone treated with hip spica. So anyone can see here, he is also length unstable fracture. So 1 month, this is 6 months. As Dr. Chetan previously said, here the angulation we can accept. Someone can see here. His clinical picture you can see there. This is shortening. He is able to sit. He has the only problem. He is just walking with extra rotation gait and shortening. So this, we have followed up to 2.5 years. So angulation is corrected. You can see from clearly 2014, the AP angulation is 20, lateral 13. It's remodeled and AP from 20 to 15 and 18. But he has a shortening. Along with mal rotation, he has a shortening. So any option here? Should we still wait or we do some intervention? So we have observed almost 2.5 years to 3 years. The shortening is progressive. Angulation is corrected, but the mal rotation is not correcting. So you can see, so we have decided where is the cora. We did the osteotomy, put the orthofixator. Simultaneously, we have corrected the rotation also. You can see gradually distraction. So here you can see he has almost 2 centimeter shortening. We lengthened the 2 centimeter. Here the clinical picture, pre-operative shortening. So his shortening is corrected. You can see here the rotation, the mal rotation is also corrected. So I have to move to last case here. As the child 6 to 8 years, the ideal treatment is we can do the close reduction, intramedullary nailing. You can see here fracture overriding. We did the close reduction is almost fracture is healed. No overlap at fracture site. 1 year follow-up of implant removal. Now from 2014, you can after follow-up of the 2.9 year, he has developed the LAD. So now what are the observation? Options, sorry, what are the options? Should we still observe lengthening of the opposite side or shortening of the same side with growth modulation? As previously we say in fracture shaft femur shortening, so we have treated with lengthening and mal rotation correction. Here is the lengthening of the.
So what is the child's problem? Is he having any difficulty in
he has a difficulty now. So this is almost when we intervene that time he has a 2 centimeter shortening. We observe. So at literature suggests it may be 1 centimeter to 1.8 centimeter lengthening can happen up to 18 months of the duration. So we have observed almost 2.9 years. Still the LAD is there and is increasing. And he just reaching near the skeletal maturity. So still we observe we can lengthen after the everything is over, but that time we have to lengthen the normal side. Or shortening of the same side.
Jaideep, can I?
Yes.
How old is the child currently?
Currently, sir, 13 point some, sir.
I think it is the right time. It's almost 3 years.
Yeah.
So it's not improving by itself. It's rather worsening.
Yes, sir.
I will consider temporary physiodiasis at 30.
Okay.
It's a male child.
Yes. So as sir said, yeah, we have just see here the Siam picture. So as sir say, we treated with the growth modulation. So you can see the pre-op X-ray and after the intervention, so both the limb are equal. So you can see here X-ray 2014, 2017, the limb length are equal. After removing the implant, still we need to follow because it's just reaching the skeletal maturity. So as I say, literature suggests we can accept the shortening or lengthening. Maximum shortening or limb length displacement till you have to observe the child up to 2 years. Then we come to know whether the limb is shortened or lengthened. Thank you. Any question? So just showing the all the scenario of the fracture. So we have a lot of different opinions. Same cases can be treated. Some cases day one we are treated. Some cases late presented to us. Yes, sir.
Excellent collection of cases.
Thank you, sir.
Yes, Dr. Mittal.
No questions.
Nice presentation, Dr. Jaideep.
Thank you, sir.
Excellent.
In adults, we accept around 1.5 centimeter of shortening, and we don't offer any surgical treatment usually for a shortening of up to 1.5 centimeter. What is the cutoff point in children?
So it depends. Generally, one centimeter up to the 1 centimeter we can accept, but depending on that, I say literature suggests that there is a different paper 0.8 to 1.5 centimeter shortening is there. In our case, it's gradually progressive. So up to observing up to 18 months, patient can remodel. After 18 months, no need to wait. You decide any intervention.
Okay. You showed your first case where the spica was applied for a neonate.
Yeah.
And you said there is a malunion. And in the second, you showed a pelvic harness, which again showed a malunion, but it remodeled.
Yes, sir.
So what should we do? We should give a spica or a...
No, sir, this spike. Ideally for neonates, the ideal gold standard is Paulik harness. As Gupta sir say, we just want to align the distal fragment with proximal fragment. The pica which was given was in extension. Okay. So here basic principle, the proximal femur always go in flexion and external rotation. We just want to align the distal fragment with this. This can be easily given by the Paulik harness. That is very comfortable, easy to use. And second case, we know Paulik harness is a good option.
Is strapping of thigh out of fashion?
Strapping of thigh also some do. But sir, we basically we want the alignment. It will heal fast. Strapping of the thigh will not flex, will not align the distal fragment to proximal fragment. It will unite, but there is a maximum chances of the mal rotation. Yes, sir.
Strapping is basically done as a temporary measure in some of the institutions where you are awaiting public harness. Most comfortable is public harness. Strapping can be done from to the abdominal side or to the contralateral normal limb, whatever you feel. But most of the centers, including mine, will use as a temporary measure. Let's say I have the privilege of getting the public harness ready every time during the daytime. But let's say child comes at night time, perhaps. My choice would be just a strapping till the time we get the public harness.
So some papers is a comparison of strapping and the Paulik harness. Lot of skin issue with the strapping also. Paulik harness gives the very less complication and is very acceptable, family friendly device to treat the fracture in neonates. Any question?
You are muted. Dr. Sirohi, you are muted.
Sir, I would like to ask this about the parents, because in the infants, everyone sees the X-ray and it's very difficult to convince. They just say this is not in thoda idhar hai, thoda udhar hai. So how do you convince the parents?
So every fracture in pediatric, so you know though. So that's why every as first says sir say what to accept, you know. So generally sometimes we just see the anyone can see the fracture X-ray on day one. So they will take they just want just like an adult anatomical reduction. But we just see the X-ray immediately post-op. We AP is always look good. Sometimes we cannot do the lateral. We know what's going to be happen. We just do the X-ray after 6 weeks or 2 months. Just know the once the child is started walking, everything is nicely. This is one of the option, and you can explain the parent. So another way, you can show the previous cases to parent when you are starting treatment before. These are the fracture, this will treat like this, this is behave like this. So counseling is very important for pediatric fracture. Counseling and show some cases. So this is my view. Gupta sir, Mittal sir, and other colleague can say
I
better.
agree. I agree. You need to counsel that, look, in a child, this fracture is 99% or so chances of remodeling. So we don't require additional surgery for that. In case we require it, we can always do it at a subsequent stage.
Yes.
This is what, and the surgery magnitude, most 99% times you will not require a surgery.
Yeah, that's why we have shown 2 cases here. So we have observed almost 2 years, 3 years, and then we did the intervention.
Then
Because
we
malnutrition.
Yeah, we need to tell them that this is going to take a little longer time, maybe 2 or 3 years for the thing to remodel. So most of the parents will understand this. I mean, I've never had an issue with this.
So the counseling is more important in pediatrics. That's the crux. And it's also we see tendency to the patients take the X-ray, taking second opinion, third opinion, and someone will say, no, I will put a small wire or I will put a small nail.
So this is happening, sir. This is happening everywhere. So it is our senior colleague or junior colleague responsibility to counterpart ours. They know what is going to be. Is everywhere in every department.
See, Dr. Sirohi, how I go about this is that if there is an apprehension on the part of the parents, I tell them, look, it is easiest for me to put in a wire and forget everything.
Yes.
Right? And you will, if you go in the market, you will definitely find somebody who is going to say like this. But this is my choice, that this is likely to remodel. Right? Will not require anything further. This may take a little time.
Yes, sir.
And this is the standard of treatment world over. I'm sure they are going to understand this.
Yeah, that's the way, sir. I usually also say that ask them, what do you do? Someone is a farmer, someone is a carpenter. I ask them to see this is not carpentry. This will become a normal bone. गांठ बनेगी, गांठ बनने के बाद जो है वो गांठ खुलेगी और ठीक हो जाएगी. That's the way.
Yes, agreed.
So one thing, if you tell the patient to follow up at a regular, say, a period of, say, 2 months or 3 months, they are more convinced. You don't just tell them one sentence and send them home. You ask them to come back for follow-up every 2 to 3 months. They are more convinced and they listen to you.
Yes.
Okay.
Yep.
Dr. Puneet.
Yes, sir.
आप बिल्कुल इनविजिबल हो रहे हैं.
No, sir. I am here, sir. So I think we should end up here.
I would request you to give a vote of thanks from Uttaranchal Orthopaedic Association.
Yeah, definitely, sir. So I would like to thanks to Dr. Gupta sir, Dr. Ravi Mittal sir, Dr. Jaideep sir, on behalf of our Uttarakhand Orthopaedic Association, our panelists, Dr. Chetan, Dr. Rama Pyari, Dr. Vivek, Ortho TV team, Dr. Ashok Shyam sir, and all our viewers. Thank you, sir.
Thank you.
Good night.
Thank you.
Thank you.
I would also like to thank all of you, sir. And I'm sorry it was a very short notice.
It was really nice discussion.
Well, it was quite interactive, I think. Everything.
Yes.
So.
And the discussion part was very good.
Yes.
And the cases from Dr. Jaideep, they really showed I think that we all have become more wiser. Thank you, sir.
Thank you. Thank you, sir, for giving the opportunity. As P.N. Gupta, sir, always in case discussion is the best person. So he has a lot of experience and good cases of collection. Yes. And thank you, Ravi, sir, for showing your nice technique. So we'll just see. Okay. Thank you. Thank you, everybody.
Thank you.
Thank you. Good.